All right. Good morning. Happy Friday, and welcome to Friday Chalk Talk. Today, I have the pleasure of introducing our guest, Dr. Kimberly Kursine. Kim is the director of the 4 outpatient palliative care clinics with Emory University in Georgia, and she's been working in the field of palliative care for 15 years. And we're delighted to have her here with us today to talk about managing our implicit bias. The format for today is going to be 2 parts. The first will start with a quick presentation, and then we'll follow that up with a little bit of time for some discussion and some questions. So, Kim, thank you for being here with us this morning, and I will hand the mic over to you.
Hi, thank you guys for allowing me to talk with you today. So we'll just run through a few slides, and I want to leave the most of the time for interactive discussion. I just want to let you know I don't have any financial disclosures, unfortunately. And I always think it's really important to kind of start with some terms so we're speaking a common language. So when I say healthcare disparities, what I mean is differences between healthcare groups who have economic, social, and environmental disadvantages. Implicit bias is the judgments or the behaviors that result from subtle cognitive processes that we're not even aware of that operate below the level of consciousness, but they are not intentional. Structural racism, if we mention that, or societal structures and policies that exclude people from minority backgrounds from accessing and participating in social institutions. So it's not a direct form of racism, it's that it's built in, disadvantages are built into the system. And cultural competency, the ability to understand, communicate with, and effectively interact with people across cultures and gaining knowledge of different cultural practices and worldviews. So I think some of the guiding principles when we're discussing implicit bias, the most important thing to know is that having them makes you human. They do have some utility. They're the reason why we don't walk down a dark alley in the middle of the night. You know, they can have some protective effects. And the important thing is they're also malleable. And why do you want to manage? So if there's something that we can't control, we all have them. Why do we need to manage them? Because managing them provides a deeper understanding of our reactions, and it also returns a sense of control and agency. So understanding why you feel the way you feel gives you the power then to alter behavior that might make your interactions better. It's also very empowering. Once you understand something, you can do something about it. And that can lead to more fulfilling patient and provider and institutional relationships. Because when you're practicing medicine, you know, we always focus on the provider and the patient, or the patient, you know, the family, but we also have to interact with our institutions, and we can have biases there that can make our jobs not very fulfilling. So I think that if you're going to be managing your bias, you know, people say don't be biased. How do you manage it? Well, there's some strategies, and what I've developed over time is that 4 parts to help me connect. So being self-aware, you have to understand yourself first before you can understand others. Then that allows you to be open enough to take different perspectives. You practice deliberate behaviors. These are the things that we do all the time to make sure that we are delivering care in an equitable manner. And then practicing really, really good shared decision making, which you can only do if you have taken perspective and you're deliberate. And all of that leads to bias management. So I want to talk to you a little bit about perspective taking. So what is that? It's the ability to look beyond one's own point of view to consider how someone else may feel or think. So there are 2 parts to even getting to perspective taking. One is cultural humility, and the other is individuation. And I sort of think about perspective taking as the road to empathy. So we often say in palliative care, you have to be empathetic, you have to practice empathy. And then we leave it at that. And people are like, how do I be empathetic? And that's a crazy question to ask. Nobody really wants to ask that. But, you know, it doesn't always come naturally. So thinking about the 2 parts, Cultural humility is defined as a person's recognition of the limitations to their understanding how a person may define their own cultural identity. It's a humble and respectful attitude towards individuals of other cultures, allowing the provider to challenge their biases and assumptions. This is basically when you walk into the room, asking the patient how they define their culture, how they define themselves, even knowing what you know, being open to hearing their interpretation. But we can't stop there. Individuation involves the conscious effort to focus on the specific information about an individual, making a more salient or decision, like trying to figure out how they're making their decisions based on their social category or information. So what I explain to people is that cultural humility lets me know about you. Individuation helps me understand the you that is making the decision at the time. So we belong to lots of different cultures, like we belong to a physician culture, we may belong to a parenting culture, we have religious or political affiliations. When we are under stress, we may make different decisions. So although a patient may belong to a certain social class in society, that doesn't mean they're making decisions based on that framework. And humans are a part of so many different social constructs that when we're distressed, we may be making decisions based on different value systems. So again, cultural humility will help me understand you. Individuation helps me understand the you that's making the decision at the time. And you're going to need both. So the question is, so to Kimberly, do we really need to be culturally competent? So most people will say, yeah, I'm culturally, I can't know everything about everybody, but I'm going to be humble. So the short answer, cultural competency still has a place because there's no way to know everything about somebody's culture, but you have to have a working knowledge of cultural norms of the people that you're treating. Like you would never attempt to go into a patient's room without reviewing the medical record. I would never attempt to palliate multiple myeloma without knowing what it is, right? Nor would I develop a treatment plan about talking to the patient, examining the patient. Well, if I understand that, hey, multiple myeloma often causes bone pain, and I walk into the patient's room and I'm like, do you have bone pain? They're like, no, I have itching. Well, oh my goodness, are you sure you don't have bone pain? Because I don't know what to do with that itching. And no, of course. You would listen, you'd be like, oh, normally they have bone pain, but this person's telling me that itching's the primary problem. Let me investigate that more. That's how we practice medicine. That's how you should approach a culture. You may understand certain things about a person who's African American or Asian American and have an idea of maybe what their history is in the country. But then now you have to listen to how they define that history. So the inability to know everything about someone's culture is not a reason not to seek knowledge. So what I explain is that it's the combination. If you want effective cross-cultural communication, you need to have some cultural competency with cultural humility, how they define it. Then you have to figure out who you're actually talking to and how they define themselves. That's going to lead you to perspective taking, and then you can actually have a real conversation. So when I think about tying all of this together, how do I kind of, just break it down into its the essence? When you walk into a person's room, you have to first start with mindfulness, and you have usually a couple of slides on self-aware, but really understanding where you are, what are your biases, why, what are you bringing to the room? So I bring my bag of explicit biases and implicit biases, my ethnocentrism, all of my experience, and I'm walking in the room to see the patient. I start maybe when I first looking at the person with some cultural competencies, pulling on, what I've been taught, what I sort of understand about the community I'm practicing in. Then after that, I'm going to talk to the person and ask them, how do you see yourself in the community? You define to me what this means to you. And then after that, after they've even defined that, that doesn't mean that even though they define what their community means to them, that they actually feel that way inside their community. Now I'm going to spend some time. So tell me about you, just you. And while I'm doing all of that, I then have to be thinking about the social determinants of health. So as this person sort of defining themselves, what are the other things going on externally, not just internally, that are affecting the way in which they move through the healthcare system, or going to create some barriers to the things that they're telling me or the things that they're wanting that I have to take into account. After I've done all that, you still not quite ready to do shared decision making. Now I have to practice some of these deliberate behaviors, because when in palliative care, I know we are great communicators, and oftentimes we're jiving with the patient, they're liking us, and communication is beautiful. But there's that 5% of people that we just don't connect with, where empathy doesn't come naturally, that we have to develop it. And how you develop it is using all of those deliberative behaviors, like therapeutic silence, asking, the I wish statements, all of those things that we teach you in fellowship or that you learn at the conferences are important. They're like your Atul Gawande checklist. You sit down, you do those things every time. So whether or not that person's your jam, or whether or not you're like, gosh, I don't really know if I can connect with this person, doesn't matter. You do those deliberate behaviors every time you give everybody the same care. If you do all that, then you can develop a collaborative patient-centered treatment plan. But the most important part is that when you're thinking about managing your biases, you're not doing it to get the outcome of, hey, if I say these magical words and I'm very open and culturally humble, now the patient's going to be a DNR and do what I want them to do. What you're doing it for is so you can accept what they are telling you. You can hear what they're telling you. You can develop a patient-centered plan, whether or not you agree with it. You're able to accept it, and that leads to trust and actually helping the patients reach their goals versus the goal that we would want for them to have. Because that we struggle with that a little bit in palliative care. Like, we want you to have your goals. We want you to reach your goals, as long as they're the goals that we want you to reach, because what we think is actually better. So I'll go ahead and stop there. So, and I hope that's helpful, but that's how I sort of tie that together, and why being mindful of yourself and your biases can help you reach to what we're actually trying to reach in our field, which is getting the patients what they're hoping for. And then also, if we are open to hearing that and we can see that, it cuts down on our burnout, because we feel like we're really helping. We feel like we're actually connecting, and it takes the pressure off of us to try to reach an outcome when the outcome we're actually trying to reach is the outcome that's going to be best for the patient, even if it's outside of our own value structure. Oh.
When we're exploring something like cultural humility and understanding why somebody wants what they want, I think one of the most useful things that comes from that is to help the people who consult us to understand why it is that people are doing what they want. Because I think the frustration that some providers may have is an assumption that somebody is not doing what I recommend because they just don't get it. Or maybe they don't understand something, and by us helping to have some of that humility, naming whatever the elephant in the room happens to be, whether it's cultural or emotional, we help the team to understand why it is that people want what they want and lower that distress.
You're absolutely right. It is difficult. We have to sort of get out of the mode of pathologizing the patient. Right. So if we've all had this, what do you want for your loved one? Well, I want them to be comfortable as possible. No, I want them to have a good quality of life. Well, then if we're doing these things, maybe we should move towards comfort care. So what would you want for them? I want you to do everything. Do you understand that if you code them that, it's likely not to work and being on the ventilator is very uncomfortable? Oh yeah, it's terrible. He suffered greatly. What do you want me to do? I want you to do everything. So once you get that, and that's like that kind of pinball, then I think it's really important to sort of step back and figure out where they're making the decision from, or what conversation you're having. apparently data in your charts. They understand that. It's not an issue of understanding. They're not making, that's not the structure they're making it from. So then you have to come back and ask, I see that you really love him. I see you don't want him to suffer. And you're choosing these things that we're worried that could cause suffering. Can you just help me understand? Because I want to be able to tell the team why you're making this decision so we can stop bothering you. And they'll tell you. And if they're making it in terms of faith, that they're saying that, look, I believe that God's going to heal him. I believe that it's important for us to continue to do this. And you accept that. Well, if you really think about it, if this is an issue of faith and he's on the precipice of death, and you're talking about spiritual things and his eternal life, and he's going to be faithful to the very end so he can reach the kingdom of heaven, then whatever you got, your skilled nursing facility or your hospice care cannot compare to an eternity with the Creator. Eternity in bliss with Jesus or hospice. I'm going bliss with Jesus. There is redemption in that suffering. Or if I'm telling you, do everything, because I can't die before the first of the month or my family's going to be homeless, then I do care about myself. No, I don't want to do this, but I love my family more. There's a hierarchy here. I cannot go until the people over here say I can go, because we're a unit and we don't abandon each other. So you do, yes, I know this is terrible. I know this sucks, but we got to do this because this is what's best for my family. That is my goal. Yes, no, I don't want 7-line chemo. Nobody wants 7-line chemo. But if my baby tells me I'm not ready, I'm not ready. So then your job is then to go back to the team and say, what's the team's distress? Well, the team feels like, I'm hurting you. I don't want to hurt you. Look, I'm doing something that you don't want. So now you go back to the team and, and explain to the team that, no, yes, this is how they want it to be. Yes, this is going to be hard, and I recognize it's going to be hard for you, but they need this. This is their death ritual. This is their Viking funeral. So when you do that code, you have honored what they have asked you to do. They don't expect it to be successful, but we need to do the ritual. Of course, the DRG is already gone. The money's spent. You were not talking about cost when you hooked up the ECMO. You do not be up. Yes, we are the budget these last few days. Death is coming no matter what. And then the palliative care teams need to think about, if the die is cast, then how can I make whatever we are doing comfortable within those confines? Because you can always be helpful. Right? You can always be helpful. You can make, if you're going to put that feeding tube in, if you are determined to do this, then let me not make this as messed up as it can be. Because you're worried that this is going to make them suffer. So the goal, then don't walk away. If you're afraid that they're going to Thelma and Louise it off the cliff, just give them a little morphine on the way down. Like we're going over there. Are we going? So, so it's a change of thought that provides absolution to the teams to know that they're not causing harm. The money people are the money people, but it doesn't matter, because if the patient ain't going and they're not willing to put them out, then the money's gone. So everybody just needs to calm down, because the more you fight, the more they're going to dig in. And then you got to let the patient, you got to do what your job said you were going to do, reach their goal. This is the goal. So I'm sorry, that's probably more. I didn't mean to get on the soapbox.
It was a beautiful and wise answer. Though I will say most people are used to people asking why, because those people want to argue with you, not because they want to understand what it is that you want. So you're working against that with most families. A lot of families, until you have enough rapport that they believe you're asking why for the right reason, not to try to understand them so you can undermine them in some sneaky way. That takes a little bit of time. It
does. And the way you said that was perfect. And that's what you say. If they don't trust you, instead of having that awkward conversation, sit down, like, I can see you don't trust me. And I have some understanding of why. But this is why I'm asking. This is the situation. And I'll tell them, the ICU is afraid he's going to suffer. They are struggling. and they're trying to do the best by you. And I know they communicate it in some crazy way. You're right. Are there financial pressures? There are. Yeah, we're in the middle. Yeah, you feel it, and that shouldn't be this way. But I need to know, because I'm here to advocate for you. And do I agree with this decision? No, I don't. I'm worried. But if this is what we're going to do, then this is what we're going to do. So I think we have to kind of have this attitude that I'm down for you. And even when they're like, if you don't go and you stay, then sometimes, like, you've had relationships where some people are easy, like you show up and you're like awesome. And then for some people, you got to work for it. You just can't show up in somebody's room and they're like, yay, doctor here.
Sure.
Yes. They don't know you. They don't know where you came from. You just walked in this room 5 minutes ago, and now you're going to tell me I have to give up my best thing.
Yeah.
Because you're ready. I'm not ready. This is going to change my entire life. So I need a minute. And I need a minute to get to know you. So, the best, the measure, I think, of how good we are at what we do is not so much how much suffering we can relieve, because we can teach anybody to do that. What we are good at is we abide the suffering. We don't go. Everybody else runs, but it gets tough, and when the emotions come, and we stay. We are constant. We do not change. We stay when everybody else says, day 105, 106, we just can't go any further. So that is that constant. And we want to see the raw truth of somebody. I want to know if you don't trust. I want to know if you disbelieve. Because if I don't know that, then after your loved one dies, you go home. I mean, we all feel good about it. We think it all went well. They may even thank us. But when they go home, you ask your hospice bereavement people, they replay that, and the guilt comes, and the family members come and say, why didn't you just believe harder? And they blame them for giving up. We don't have to deal with that. They do. So they need to be right about it for what's happening in the moment, but also what's going to happen in the aftermath of that moment. So that, and I do feel like that's our responsibility, not to leave them hanging.
Yeah. Well, one more quick question, and then we'll let you go on this beautiful Friday. Maybe more of a comment, and it is, I feel like the most raw and real conversations I have had is when I just am kind and blunt about naming the elephant in the room. In particular with cultural, I can think of a particular case where after maybe spending an hour with someone, I felt like I knew them maybe enough to ask them, how is it being a Black woman in healthcare? I could feel that there was mistrust there, and that opened up exactly what I needed, because you could feel there was some disconnect. Something had happened to this poor lady in the past, and there was mistrust, and naming things helps.
Yeah, that's perfect. People want to believe you. Yeah. We communicate. People ask all the time, like, how do you communicate cross-culturally? And I laugh. I say, it's totally possible. I have a 5-year-old son, and we live in Asian and African-American neighborhood, and he goes to a school with majority white children. He wants friends. He figured it out. And, Black, and immigrant doctors, we don't get a book on we don't get there's no webinar of dealing with white people. There is none. You just do it, and they, so it is possible. And it's by asking those questions, and they can accept those questions, because people want to believe you. When you walk in that room, you represent hope, no matter who you are. And if you're willing to ask me that question, that shows that you care. You just have to be ready to hear the answer. And if you can hear the answer without judgment and acceptance, then we make that connection. So I do believe that, race concordance and diversity is really important, but that's not always possible. And we make plenty of these connections and develop affections for each other when we have vastly different backgrounds. So that is always possible if when you bring your most authentic self. People know when you bring the real you, no matter how you bring it. They don't expect you to be perfect.
Perfect words to end on.
Okay.
All right, Kim, such a pleasure to have you with us today. Thank you.
Thank you and good luck to you. It's very nice to meet y'all.
Absolutely.
Bye.
Take care.